Well, thanks for letting me share this lecture. I'm going to talk about moderate traumatic brain injury and a clinical approach to an inappropriate term. Inappropriate term because I think that we don't have a good evaluation of this patient, and maybe it influence in the outcome of this subgroup of patients with traumatic brain injury. You have to remember that there is not a clinical guidelines for management of moderate traumatic brain injury. Despite this subgroup of patients represent about 15 to 20% of all the patients with traumatic brain injury, if you consider moderate TBA as patient with admission Glasgow outcome scale from 9 to 13. And the mortality of this subgroup of patients is a little high, I think, because in the different publication, especially in low and middle income countries, the mortality of this subgroup of patients fluctuate between 6 and 15% of them. And if you talk about, or if we talk about the outcome and you use the Glasgow outcome scale extended, I want you pay attention in moderate disability. It is to say GOS extended 5 and 6, because they are patients who are able to live independently, many of them only in home, but they are unable to return to work or to study or to do it with reduced capacity. And what is the importance of that is that about 30% of patients has moderate disability at 12 months when they present a moderate TBA. And this is a big number of patients who survive, but they live with a moderate disability. And most of this disability is based on cognitive sequelae that are very disabling for the patients, associated with diffuse axonal damage, not necessarily proportional to TBI severity. And some of these deficits are usually evidenced by attention deficit, memory and learning problems, mood and personality disorder, and language disturbance. So, summarizing, a final result of patient with moderate TBI depends on at least 3 aspects. The first of all, primary injury, that in this subgroup of patients is not devastating. Secondary brain injury, that is depend of us. It depends of neurocritical care. And finally, it's depend of the neurorehabilitation that sadly is not available for all of them. So, who are the patients at risk of word evolution and poor outcome? I believe that this is the right question. We need to try to recognize this group of patients with a higher risk of mortality and poor outcome, despite an admission Glasgow between 13 and 9. I am going to talk about some couple of words about outcome factor as age, trauma kinematics, Glasgow coma scale, and CT scan finding in this subgroup of patients. If we talk about age, increasing age is a strong independent factor in prognosis, with a significant increase in poor outcome above 60 years old, with aggravating factors as the common use of anticoagulation and or antiplatelet drugs in this subgroup of patients. If we talk about trauma kinematic, direct impacts on the skull are associated to the breast fracture, epidural and subdural hemorrhage, but mechanisms that include acceleration, deceleration forces cause diffuse axonal injury, swelling, and brain contusion, and it is much more deleterious for the brain, especially in severe and moderate TBI. Regarding Glasgow coma scale at admission, moderate TBI include a wide spectrum of patients. You can see patients who talk and obey, for example, Glasgow 13, or with a motor score of 6, or you can have patients who only flex to withdraw from pain. For example, Glasgow 9 with a motor score of 4. 75% of moderate TBI deaths were Glasgow 9 and 10 patients at admission with a Glasgow with the motor score of 4. Remember that motor score has almost the same predictive value than full Glasgow coma scale. For this reason, I believe that in moderate TBA, we should consider as a red flag motor score of 4 and 5 in this subgroup of patients. And you can see in the figure. I believe that both patients have Glasgow 9, they have different motor score, and they are not similar patients. Regarding CT and traumatic brain injury in moderate TBI, remember that CT finding allow us to predict the risk of intracranial hypertension and are associated to patient outcome. For example, focal mass injury, midline chief, basal cistern state, or traumatic subarachnoid hemorrhage. Regarding midline chief and outcome, despite 5 millimeters midline chief is the threshold considered in Marshall CT scan, the relation between degree of midline chief and outcome at 6 months is essentially linear, as you can see in the paper of Mass of a couple of years ago. Regarding basal cistern, remember that effacement of the perimesencephalic cistern increased the risk of high ICP 3 times. But when you analyze a CT scan in the emergency room in a moderate TBI patient, you have to make the difference between 3 different states of basal cistern. For example, normal cistern, compressed cistern, and absent cistern. The figure in the middle are cisterns that are visible but are not normal. And in the traumatic coma data bank, the basal cistern state in the 3 different states has different mortality for patients, and is very important. And remember that center TBI show us that at least 30% of the CT scan evaluated by a neurosurgeon, neurologists, emergency department physicians has mistake to evaluate the state of basal cisterns. Finally, if you consider the Marshall classification, I like to show you this figure from Dr. Apoca from Spain, because we can explain it in a very didactical way. For example, if you consider diffuse axonal, diffuse injury 2, 3, and 4, the risk of intracranial hypertension in this group of patients is 30, 60, and 100%. So it's so easy to predict the risk of intracranial pressure if you analyze correctly the CT scan. Regarding type of intracranial injury in moderate TBI, I just want to say something about brain contusion, because brain contusion are very common in moderate TBI, especially in older people. These injuries are associated with a worse outcome, are very heterogeneous in its presentation and evolution. 50% of brain contusion progress in the first days, and they have a very complex pathophysiology that include excitotoxicity, powerful neuroinflammatory response. They induce brain edema, increase intracranial hypertension or intracranial pressure, trigger cerebral ischemia and hypoxia, and finally cause neuronal death by apoptosis or necrosis. And there is a lot of mechanism, pathophysiological mechanism for brain contusion progression. And I want to show you that especially there is an activation of molecular cascade that will produce, for example, late hemorrhage and edema in brain contusion. And mechanisms as sulfonylurea receptor, metalloproteases, and aquaporins are very common molecular pathway for secondary brain injury. But if we go to clinical scenarios, what can we see in moderate TBI patients? For example, you have 4 different patients with different age, different Glasgow Coma scale at admissions, with different kinematic of trauma and different CT scan. All of them are a moderate traumatic brain injury. But I think that all of them have or need different clinical approach. For example, the first patients just need surgical evacuation of epidural hemorrhage and clinical monitoring after or post-surgery. The second one, for me, is the most severe patient because he is 45 years old, Glasgow Coma scale of 10 with a motor score of 4. He was hit by a car. He has, for example, a Marshall 3, in my opinion, and he needs ICU admission, ICP, and oxygen, brain oxygen monitoring. Finally, the last patient is the older with a Glasgow of 13 with a basal bifrontal basal contusions. This patient should be admitted in ICU 2 and strict but not invasive monitoring. We can discuss about this clinical approach, but I think that all of these patients have moderate TBA, but they are very different and they need a different clinical approach, especially to avoid secondary brain injury. About moderate TBI management, what about medical treatment? The main goal of medical treatment of moderate TBI is the prevention of secondary brain injury. That is depend of our level of neurocritical care. And the prevention of secondary brain injury is very simple. We just need to maintain the homeostasis of the brain. So we need to have a very strict glycemic control, natremia control. We have to avoid hypotension from the pre-hospitalized attention to the ICU management. We have to ensure the adequate brain oxygenation and, of course, temperature control. Regarding neurosurgery, especially in brain contusion, sadly, there are few clinical recommendations. For example, a Bullock, 15 years old, years ago, he published this recommendation. And in moderate TBI, the only one recommendation is the evacuation of any focal intraparenchymal mass injury greater than 50 ml. In this sense, I would like to show you the stitch that is the early surgery versus initial conservative treatment in patients with traumatic intracerebral hemorrhage. This study shows us that there is a strong case for operating patients with traumatic intracerebral hemorrhage who have a Glasgow Coma scale of 9 to 12 because they have the best response to early surgery. But once the Glasgow has descended below 9, surgical intervention appears to be less effective. What does it mean? That we have I am a neurosurgeon, and I believe that we have to be more aggressive. We have to indicate the surgery early in the evolution of a moderate TBI patient because they are going to have a better response to early surgery. But maybe it is not going to be very useful when the Glasgow Coma scale has descended. regarding ICP monitoring is so simple. Brain Trauma Foundation, there's not a recommendation for ICP monitoring in moderate TBI patients. But why I think that we have to measure ICP in some cases of moderate TBI? For example, here we have 5 studies in which ICP monitoring was used in 11% of patients, but intracranial hypertension with a threshold of 20 or more was found in almost 50% of them, the first data. The second reason for measure ICP in moderate TBA is the concept of dose, the concept of dose of burden of intracranial hypertension. You can see these 2 patients, they have the same mean ICP of 16, but if you look at the patient below, you can see that he presents 2 moments of intracranial hypertension with ICP above 20. What they do, they measure, they calculate the area under the curve, and they express that as millimeters of mercury per hour. And this is the dose of burden of intracranial hypertension. And what is the relevance of that? The relevance is that dose of intracranial hypertension is associated with outcome. With more dose of intracranial hypertension, more bad is the outcome. So for this reason, we don't have to concentrate our treatment in the main ICP. We need to control the peaks of ICP, and we have to try to be aggressive with the treatment for these patients. And the final reason to measure ICP in moderate TBI is found in the rescue ICP study, in which you can see, this is from the supplement of the rescue ICP. And you can see that from 400 patients, 100 of them, as you can see, were patients who were admitted in Glasgow 9 to 15. It is to say, they were mild TBI, moderate TBI, and they finally result in refractory intracranial hypertension, and they need or aggressive medical treatment or the composite craniectomy. What is the future about a moderate TBA? Obviously, we need a better understanding of pathophysiology and the different mechanisms of brain injury. Maybe we need to improve the neuromonitorings, and maybe biomarkers are going to be very useful in the future to evaluate every single brain injury mechanism to avoid and to treat the different cascade of brain injury. We need to make a real precision medicine with traumatic brain injury. Remember that we base on hydraulic monitoring, it is to say peak, ICP, and CPP, all of our treatment about patients. But someday we are going to be able to inhibit, for example, SUR1 receptors, or maybe we will be able to modulate metalloproteases or aquaporins. So we have to improve our basic science and to finally make a real precision medicine with traumatic brain injury patients. Obviously, technology is going to be very useful too. Big data neurocritical care will allow us to interpret a greater amount of data for making decisions. But what can we do now? I published in December of the last year this article in Critical Care Medicine, in which we propose a new classification of potentially severe traumatic brain injury based on clinical and radiological characteristics. As you can see, we use a traffic light method to consider the classification and the clinical approach with the patient. For example, a patient with a Glasgow of 12 with a diffuse injury 2 is a yellow, like it is to say a high alarm. But in a patient with Glasgow Coma scale of 10 with a Marshall 3, I believe that this patient has imminent danger and we have to be very aggressive with our clinical approach. Maybe it's going to make the difference between at least two subgroups of patients. Recently, I published it in a Chilean brain neurosurgery journal, these algorithms in which I try to make the difference between moderate TBA patients with Glasgow 11 to 13 and patients with Glasgow 9 or 10, especially the patient with diffuse injury Marshall 3 and 4. This subgroup of patients with moderate TBA, I believe that they need to be included in a severe TBI protocol, monitoring and treatment. They need to be admitted in ICU. They need maybe ICP, maybe a brain oxygen monitoring. Because I think that if you want to avoid the secondary brain injury in this subgroup of patients, we need to consider Glasgow 9 and 10 with Marshall 3 or 4, the new severe traumatic brain injury patient. Maybe we are going to improve the outcome of this subgroup of patients, I believe. Finally, my conclusions are that moderate TBI requires a new clinical approach, maybe a new classification. Patients with Glasgow of 9 to 13 on admission are rescuable. However, up to 15% die during the revolution. And this is a problem, a big problem, I believe, especially, for example, in Latin America or another low and middle income countries. I believe that Glasgow 9 or 10 patients, more Marshall 3 and 4, must be identified as patients with a higher risk of worse evolution. A moderate TBI, I believe, that give us an opportunity to avoid secondary brain injury and increase good outcome. But to make it, we have really raised the bar, maybe seeing it hard, but we have to try to do it to improve the outcome of patients with traumatic brain injury. Thank you so much.